Hi, everyone. I'm Jeanne Meserve. Thanks for joining us for our event cast, People v. Cancer, Equity in Care. The battle against cancer pushes against the limits of science and human will and perseverance. But when it comes to the very latest in treatments and technologies, not everybody has the same access. Cancer patients of color too often find that their needs are not being met. Today, in the first of a series of events of People v. Cancer, we're going to be looking at how this inequity in care impacts patients and providers and institutions. And we're going to talk about what can be done to improve care for all. Over the next hour, we're going to be looking at the causes of this inequity and at some novel approaches for addressing it and improving cancer outcomes for all. If you're watching, let me remind you that we want to have your participation. You will see at the bottom of your screen a Q&A function. Use that to send us your questions. Please keep them short, on topic, and please let us know where you're watching from. I also want to acknowledge the support of Bristol Myers Squibb for the Atlantic's Journalism Today. And now for some introductory remarks, let me introduce Dr. Samit Hirawat. He is Executive Vice President and Chief Medical Officer of Global Drug Development at Bristol Myers Squibb.
Hello, and welcome to this special episode of Atlantic's People vs. Cancer virtual series. My name is Samit Hirawat, and I'm the Chief Medical Officer at Bristol Myers Squibb and also lead global drug development for the company. My colleagues and I have the great honor to come to work every day, focused on one mission, transforming our patients' lives through science. This is especially true for those living with serious diseases such as cancer. We are constantly challenging ourselves, asking ourselves, what new discoveries can we research and advance in order to bring forward new medicines that will solve our patients' unmet needs? As part of this mission, we also envision a world where everyone has equal access to quality care. We call this health equity. When it comes to clinical trials, we believe health equity for cancer patients means three things. First, that all cancer patients have the opportunity to benefit from new medicines that we are developing. Second, that the research we do must start with a deep understanding of our patients' experiences and unique needs. Based on that information, how will we then develop new therapies that will better treat their diseases and improve their lives? And third, that our clinical trials reflect the diversity of the people burdened by cancer. By expanding trial diversity, we are able to learn from these patients and narrow racial gaps in treatment. We have long invested in driving diversity and inclusion in all aspects of our business, from our people, suppliers, and research partners, to where and how we conduct our clinical trials and the reach of our medicines, reflecting the growing diversity we see in patients we serve. However, the global COVID-19 pandemic has further exposed that there is more to be done. Persistent health disparities have put under-resourced minor communities at great risk of poor health outcomes. Now more than ever, Bristol Myers Squibb recognizes our role in creating the change needed to address the health disparities and racial inequality present in our community. Given the urgency of this need, our company is acting quickly and with purpose to advance our health equity and clinical trial diversity efforts. We recognize that this is going to reach a more diverse patient population impacted by cancer. We need to make participation in clinical trials more accessible to patients of color. Earlier this summer, we made a series of commitments that will, number one, ensure that we are embedding and bringing clinical trials to the communities where patients live. Secondly, build a clinical trial infrastructure and support workforce development programs to increase the diversity of clinical trial investigators. This will help diverse patients see themselves in the clinical research community and further build trust between the medical community and their patients. We are pursuing these initiatives because we are committed to meeting the health needs of everyone who can benefit from our medicines. That said, addressing systemic inequities will require systemic change. During People vs. Cancer, we will be sharing with and learning from the program participants to further this important work. As you participate in People vs. Cancer events, I urge you to think about 3 questions. 1, what does representation in cancer care mean to you? 2, what barriers must we overcome to instill greater health equity in cancer care? And 3, how can the cancer community work together to advance health equity, improve trust, and drive more diversity in clinical trials? With that, thank you for your participation in today's program, and we at Bristol Myers Squibb look forward to continuing the conversation in November. Thank you.
How will I know?
Thank you, Dr. Hirawat. And now for our first conversation on health disparities in cancer, let me introduce our moderator, Ray Suarez.
Thanks a lot, Jeanne. Great to be with you all. Our first session is called The Health Disparities of Cancer. This pandemic, the affliction that's forcing us to have this conversation remotely rather than face-to-face, is said to have exposed inequalities that are always there. We're just forced to see them a little better now. Well, are we? And how do those inequalities show up in healthcare, and particularly in cancer treatment? For that, I'm joined by Dr. B. Lee Green, Vice President of Diversity, Public Relations, and Strategic Communications for the Moffitt Cancer Center in Tampa, Florida. He's also a professor in the Health Outcomes and Behavioral Program at Moffitt. Dr. Green, welcome. Hospitals don't always have a VP of diversity or a health equity officer, so we should really understand a little better what it is you're asking about and what it is you see.
Great. Thank you so much, Ray, for having me, first of all. So maybe a little bit about my role at Moffitt as the Vice President for Diversity, Equity, and Inclusion. So I think it's safe to say that my work and the work of my teams probably touches every single level of the organization, because we are responsible for all of the diversity, inclusion, and equity work across the Cancer Center. So our work is around ensuring that the Cancer Center overall reflects the communities that we serve, making sure that we educate our team members to identify and meet the unique needs of our diverse patients. I think it's also important for our work that we are recruiting a diverse group of team members in collaboration with our HR colleagues. And we try our best to keep our finger on the pulse of the organization on all issues around equity and inclusion. And then I think it's also very important that we develop those key relationships in the community to ensure that the folks in the community that we serve understand that Moffitt is a valuable resource to the community.
You know, when there's a breakthrough, a new technique discovered, a new cancer drug developed, there's no racial aspect to the story. Yet we now know, or are given to understand, that the way different Americans get treated after diagnosis is different. How? How do those inequalities express themselves in the treatment and aftercare environment?
Yeah, that's a great question. One of the things that we know, and it has been well documented, and that is that certain minority populations, when they present for care, and not just in cancer, but I think across the board, there may be differences in how they are treated. with regards to, are they put forth for more of the advanced treatments? Are they relegated to surgery as opposed to some of the other more unique care needs that they may actually have? So we know without a shadow of a doubt, we know based on research that when minority populations do present at healthcare centers, they may be treated quite differently, which is certainly something that all of our institutions need to be looking at to ensure that we are not treating those patients differently, but that they are getting the best possible care that they can get when they show up at our cancer center.
Help me understand how much race is actually involved and whether we have to be careful about using race and ethnic origin as a proxy for socioeconomic standing. Is a low-income white person going to have worse outcomes, worse treatment than a low-income peer of color? Is a high-income Black patient going to have treatment outcomes that resemble a white peer at a similar income, education level, insurance status? Or are these differences that are showing up really heavily correlated with race and ethnic origin?
Yeah, that's a great question. And I think the short answer to that is absolutely. Race does play a factor or play a role in the outcomes that people see when they are showing up for care. But to your point, when we look at some of the causes of health disparities, we can look at things like low socioeconomic status. We know without a shadow of a doubt that those individuals who are on that lower end of the socioeconomic status will have lower health outcomes, or poor health outcomes, I should say. Even geography, when we look at where people live, regardless of your race or ethnicity, if you live in rural areas, for example, we have seen studies to show that your health outcomes may be poor than those folks who are living closer to healthcare facilities or more in our city dwellings. So absolutely, we see those differences across the board, but research has shown us that we absolutely see them showing up a little bit more with regards to race and ethnicity.
Now, you've said that in your work and your research, which involves a lot of statistical data, you keep the memory of your grandmother front and center. Why? How does she enter into the story?
Yeah, that's another great question. So I grew up in a household where we ended up having to take care of my grandmother, who suffered significantly from diabetes. Ended up having to have both of her legs amputated as a result of that. And as a young boy, I was involved in her care, and it was quite traumatic, as a matter of fact. And as I do this work, I keep her memory front and center because as researchers, if we continue to look at the data each and every day where we see these disparities, we see these inequities, sometimes we can become immune to the data where it does not make an impact on us. And so for me, I keep her front and center. There's a quote that I often use, that data are real people with the tears wiped away. So every time we look at a data point, we're looking at a real person. We're looking at someone like my grandmother, who has a family, have people that she loves, who takes care of her. And so for us as researchers, I think it's important for us to keep the real patients in front of us so that we do not get immune to what we see on a day-to-day basis.
Well, let's combine the data and the people. When you widen the lens, when you look at America as a whole, is it fair to say that doctors simply treat Black and brown patients differently from the way they treat white ones? Whether it's listening to their complaints on the front end around the time of diagnosis, managing their pain or discomfort during recovery, do you just flat out get treated differently?
Yeah, there's no question, and I have a personal example of that. When I first moved to the Moffitt Cancer Center here in Tampa, Florida, one of the first things that we do, Ray, is we find a new healthcare provider. And I found my provider, went in for my checkup. And one of the things that I noticed immediately, based on my age, based on my history, was that I needed to have a prostate screening. There's no question about it, based on my risk factor as a Black male. What I found when I went to this new provider, he never touched me, never, examined me. It was just a question and answer session. Never asked me about my family history. Never asked me about, if I've ever had a prostate exam. And I could tell from that point that he was absolutely treating me differently from what he would treat some of the other his other male patients. Not sure where it was coming from, but my sense was the fact that I was a Black male, that he did not take the same seriousness of this exam that he might take with another male. The other thing I'll mention is I was involved in a study many years ago where we looked at Black men and their prostate cancer treatment. And we found clearly in that study that the Black men who were being treated for prostate cancer ended up getting surgery probably 90% of the time compared to the white men who we had in the study. The white men that we examined had a combination of surgery, radiation, chemotherapy, what have you. So they had a wide range of different treatment options that they utilized, whereas the Black men, 90% of them had surgery. And when we talked to the physicians about that study, one of the things that they said was, well, because of the fact that Black men tend to be more non-compliant, we thought that surgery would be the better option for them, as opposed to saying, here are your options. What do you think is the best option for you? That study was an eye-opener for us, because it was clear that there were some preconceived notions about the Black men in the study, that it was best for them to get treated with surgery, because that would be best on their lifestyle, because they may not follow up like they should with the other treatments.
Now, in medicine, like in a lot of areas of our common lives, when you find out you're doing something wrong, when you measurably, through research, through investigation, find out that something you're doing is not working or working well, you stop doing it, or you put protocols in place to at least start the process of changing old habits. Why is this set of factors that you're describing harder to address than just saying, well, don't do that anymore?
Yeah, that's a great question. I think the fact of the matter is we need to place this as a higher priority as a society, and not just from a society level, but also from an institutional level, that the leaders in our institutions, the leaders across the country, we must put health inequities, health disparities as a national emergency. And I think until we do this, we will not see the change that we need to see as a society. So I think we all have to step up and ensure that health disparities, health inequities become a high priority for us across the country and also within our institutions. It is absolutely critical. And until we do that, 5 years from now, 10 years from now, we will still be having these conversations. Ray, the one silver lining around COVID-19, and as we all know, COVID-19 shined a light on disparities overall. Those of us who work in this space, we were not surprised when those numbers came out that it was disproportionately impacting minority populations. And so for us now, because a light has been shined on this issue, I think this is an opportunity for us to step up as a society, as a country, to say, you know what, this has been going on for too long. It's time for us to take this extremely seriously and move it to the top of our agenda as a national issue.
You're one of the leaders of something called the Tuskegee Legacy Project, and you've called it one of the highlights of your career. Tell us about the project, why it's important to you, and maybe begin by reminding our audience of the significance of Tuskegee in this context.
Yeah, absolutely. So I'm sure many of our viewers have heard about the syphilis study at Tuskegee, where there were 399 Black men who were diagnosed with syphilis, but they were withheld treatment to see how their bodies would respond to syphilis without treatment. Back in the early 90s, when I was working on my dissertation, the syphilis study at Tuskegee kept appearing in the literature as one of the main reasons why Blacks do not participate in clinical trials or research studies. But what I found interesting, Ray, was that many of the comments in the literature about the syphilis study were all anecdotal, that there was no data to support the claim that Tuskegee was, in fact, the reason why people were not participating. So I collected data to try to answer that question of the impact of the syphilis study with actual data. And as a result of that work, I was invited to be a part of the Syphilis Study Legacy Committee. And this committee was made up of other individuals across the country who wanted to also answer this question about the syphilis study. My main connection to the study, I should mention his name, Dr. Ralph Katz, who was a professor at NYU. And he and I had very similar interests and worked on several research studies around this issue. The Legacy Committee was formed back in, I want to say, January of 1996, and had several goals. Number one was to see what the damage was, the damage that was done to the Black community as a result of this government-led syphilis study. Number two, the group wanted to talk about strategies. What are some of the strategies to address the damages, if they in fact exist as a result of this study, and what can we do today to address some of those damages? And then number three was the big one, and that was to persuade President Clinton to apologize to the men and their families for the atrocities of the government study. And I say it was the highlight because being a part of, I was invited to the White House for the formal apology, and to be there to see those men finally get the apology that they deserve, the apology that their families deserve, was just, it was incredible to be there. And I should say, I always mention this, that when President Clinton uttered the words, "We are sorry," I don't think there was a dry eye in the place. And I think that was the case because I think we all knew that a huge weight had been lifted off of the men and their families, because this was the first time in their lives that the government had acknowledged what they did was wrong and apologized for it. And I think that was a major step in terms of the healing process for the African-American community in particular.
Dr. B. Lee Green is Vice President of Diversity, Public Relations, and Strategic Communications for the Moffitt Cancer Center in Tampa. He's also a professor in the Health Outcomes and Behavior Program at Moffitt. Professor, thanks a lot. Great to talk to you.
Thank you so much, Ray. Really appreciate it. Take care.
And now let me turn it back to Jeanne Meserve. Jeanne?
Ray Suarez and Dr. Green, thank you both. We're now going to take a look at genetics, specifically at expanding genetic research. We have a couple of great panelists. Let me introduce them. Dr. Harold Varmus is a Nobel Prize winner. He is also a professor at the Meyer Cancer Center at Weill Cornell Medicine. Also joining us is Dr. Onyinye Balogun, a radiation oncologist at Weill Cornell Medicine and a recent recipient of a Genome Center Genetic Research Grant. Thank you both for being here today. Dr. Varmus, I'd like to start with you. You won your Nobel Prize looking at genetics and cancer. In layman's terms, can you explain to us your findings?
Yes, well, let's keep this brief because it's really not on the topic anymore. But we showed many years ago that by working with a virus of chickens that causes cancers, sarcomas, that we could identify the gene in the virus that was responsible for the virus's ability to cause cancer and trace that back to a normal cell that is found not only in chickens, but in all vertebrate and indeed all metazoan species. And that was the initial moment at which we realized that the cancer largely arises from our genetic inheritance and from mutations that affect certain genes that play important roles in normal development and normal operations of our cells.
Do we know enough yet about the genetic differences between Blacks, whites, Latinos, Native Americans, and how that may impact the rate at which they get cancer, how virulent the cancer is, and so forth? Or are there still big gaps in that knowledge?
There are big gaps, and that's indeed why we're talking today, because the New York Genome Center, where I also work, decided about 3 years ago to spend more time thinking about and investigating the abnormalities in our genes that either are inherited or occurred during life to produce a cancer, and that information is found. The information we have in hand comes largely from people of European descent. We have large databases of information that has been produced by studies done to a very large extent under the auspices of the National Cancer Institute throughout the country. And yes, there are minority patients who've participated in those studies, but not in the numbers that we would like. And to do these studies properly, the emphasis should be on diversity, because the more diverse the universe of people we study, the more likely we are to make discoveries. Discoveries are what promote better care and better outcomes in the long run by improving our understanding of how cancer arises. So we've been interested as scientists working at many institutions throughout the New York region in trying to make use of the diversity of New York City's population to increase the diversity of people whom we look to for materials, both normal DNA and cancer-derived DNA, that will help us understand the variations in DNA, mutations and inherited variations that may contribute to the cause of cancer. That is not to say that there aren't a lot of other reasons that you've been hearing about from Dr. Green just a moment ago that explain the diversity, the shortcomings and outcomes.
Dr. Balogun, I'd like to get your thoughts on why there hasn't been more genetic research on some of these other populations.
So I think, first, thanks for having us. And I think one of the reasons is, as you know, Dr. Green just touched upon, distrust. So frequently, in order to get access to these types of genetic studies, you have to be enrolled in trials, and sequencing can be expensive. It's not something that we usually do for every single patient, but we like to do it for patients in whom it's indicated. And frequently it is part of clinical trials. And if the individuals are not part of a clinical trial because of the mistrust due to horror stories like Tuskegee, due to other atrocities that have been committed in the name of medicine, they won't have access to it. So that's number one, lack of participation in clinical trials. And two, it's an expensive process, and minorities, individuals who are Black, Hispanic, may not have the resources to out of pocket pay those expenses. So that's why I'm excited about the P1000, because it takes out at least the initial issue of expense. And also we're going to be engaging the community to hopefully overcome the distrust and give access to genetic studies.
Is it also possible that, go ahead, Dr. Farmer, excuse me.
I just wanted to emphasize that in my experience, one of the deficiencies in medical research has been not just that people of color are suspicious about research. That actually is a factor, but often it's just a neglect of seeking out the most diverse possible population. Because in my experience, in general, Black and Hispanic patients that I've seen in my experience as a physician as well as a researcher are eager to participate in science once they understand what the risks and benefits are. And it's our determination to include those patients and to enrich the population of scientists who are conducting those studies by trying to include people of color in the scientific community in greater numbers that play a very major role in trying to make science equitable and able to deliver the wide range of results as possible when we are inclusive in our practices.
Dr. Farmas, you've mentioned the New York Genome Center and the grants that you're making. How many grants? How long do they last? How big a dent is this going to make in this gap in research?
Yeah, well, that's an excellent question, and we don't pretend to say that we're going to solve the problem. We have limited resources, but we have a few $1 million that have been donated by generous benefactors of the center. That's allowed us to put together enough money to support research in 7 different projects carried out at many different hospitals and academic health centers in the New York area over the course of the next couple of years. We do think that we will have an impact by simply looking at the genomes of several thousand cancers. We've been helped in this regard by donations from industry who want to see the sequencing technologies they've developed more widely used and more equitably used. And we think we set an example. We produced additional data that might produce discoveries. We encourage scientists to participate in these studies and encourage physicians and undergraduates of color to enter the scientific community, recognizing that we are now paying more attention to issues that may be of special concern to them. So I think there are many ways in which we can be emblematic of a change in the way science is trying to approach diversity in its efforts to understand basic mechanisms of disease.
Dr. Balogun, you're a recipient of one of those grants. You are looking specifically at endometrial cancer. Tell me why that cancer, is that disproportionately affecting African-American women?
Yeah, so endometrial cancer is actually the 4th most common cancer amongst women and the 6th most common cause of death. And what happened is that I was, as part of a master's program that I'm undertaking, I actually initially planned to study cervical cancer in New York City to look at potential disparities between people of different ethnicities. And what I found was that cervical cancer actually has gradually over the years, due to screening with the Pap test, due to earlier detection, has done quite well and continues to decrease in terms of deaths and incidents. Out of curiosity, I looked at endometrial cancer in New York City and also the United States, and it was astonishing what I saw. The rates are going up. For Black women, the rates have gone up 2% per year for the past 10 years. For white women, it's gone up 1% per year, and the mortality rates are increasing. So while you're hearing of success stories in things like lung cancer, this was a year where they saw a decrease in the rate of lung cancer deaths. Endometrial cancer is trending in the wrong direction, and it's slightly more likely to affect white women. However, Black women are much more likely to die of endometrial cancer. The 5-year survival rate for a white woman is 86% in the United States, and it falls sharply to 64% for Black women. So it's certainly an area that we needed to look into. And what we're doing is we're going to look at samples of endometrial cancer from Black women who tend to get more aggressive forms of endometrial cancer. Why is that? We're not sure, but we're hoping that by looking at a population enriched for Black women, we can start to tease apart why do they get these more aggressive forms of endometrial cancer? Why are they more likely to die? What contribution does genetics play in this? And this is not to say, as other people have pointed out, that there aren't other factors. We know that there are issues of going to your doctor with symptoms and being turned away and told that your postmenopausal bleeding is normal. I've unfortunately had to see patients like that who just were not taken seriously. So we have other issues, including structural racism in medicine that we have to address, but there is a role of genetics, and we're now going to start teasing that apart.
I think it's also important.
We were talking earlier. Go ahead, Dr. Varmus, excuse me.
I was just going to ask Dr. Balogun to say something about the places where she works and where she interacts with these patients, because it's very important in these studies to extend ourselves beyond the high-profile academic health centers that you read about so often to hospitals that are embedded in the communities in Brooklyn and Queens and the Bronx, where medical research is sometimes not as intensively pursued.
Exactly. So in our study, we are going to focus on women who come to Brooklyn Methodist Hospital and New York Presbyterian. So I love serving this population of women. And we are also going to be collaborating with Northwell Health and Cold Spring Harbor Laboratory. What I love about P1000 is that they put us in touch with other institutions that want to study this question and address this question. So we're no longer just working in silos, each individual trying to tackle this question. We're going to be looking at populations that are usually medically underserved. So we're going to basically look at populations in Brooklyn and also at the other institutions that I mentioned.
Oh, we have a couple of audience questions. Go ahead, and then I'll work to the audience questions.
I'm sorry to interfere with your moderating role, but I think it's also important in the context of this particular disease to think about the role of ethnicity and the kinds of studies that we undertake, which analyze the inherited genome, the DNA you get from your parents, closely in a way that goes way beyond the traditional assignment of racial categories that are very limited in their perspective. And what we're looking for here are variations in DNA that are associated with having ancestors who come from Africa. And Africa is the most diverse place in the world.
Yes.
And the kinds of things we may be looking for as contributors to the incidence of endometrial cancer may well be specific for certain parts of Africa, and they become the kind of identifiers that allow us to say this person is a particularly high risk, and that allows, as in the case of the breast cancer genes that you're probably familiar with, a way of saying to an individual, you're at especially high risk, and preventive strategies should be particularly carefully followed in your case.
So you just made the connection that I was hoping we'd get to about why this matters, of how knowing the genetic profile of an individual and how it may relate to the disease could impact diagnostics and treatments and outcomes. Could you talk a little bit about that, please?
Sure. So
I mean, there are many ways. There are many ways in which the DNA you inherit can make a difference. It may just be a matter, as in the case of the breast cancer susceptibility genes that many people are familiar with, that you're at a higher risk of getting the disease. But there are other factors to take into consideration. For example, some people may have different responses to environmental causes of mutation, or people may have different reactions to a treatment that's being used. So there are many factors that are part of our genetic inheritance that may affect the likelihood of getting a disease, the likelihood of responding to certain therapies, the likelihood of the need to avoid certain environmental factors that may contribute to mutation and to the appearance of disease. But of course, these have to be considered together with social factors that we were talking about earlier, having to do with socioeconomic status, inherent racism in our society. So there are a lot of factors. It's very we recognize that at the New York Genome Center, where we're carrying this out, we're exploring one important but not all-encompassing effort.
And just to piggyback
one audience question, if I could get to one or two here. Somebody asked, are you sequencing the tumor or are you sequencing the individual? Dr. Balogun?
So we're getting samples from both the tumor and normal tissue as well as blood. So we're going to look at all of those in order to understand, are these mutations that are within that individual, or are they mutations that are novel that arose in the tumor? So we're going to be able to look at different types of tissue in order to determine that. And I just wanted to add a little bit regarding the impact on therapeutics. So one of the most recent trials on endometrial cancer that has influenced how we treat advanced disease, which Black women tend to present with, was performed primarily in the United Kingdom and the Netherlands. So that population has now influenced the therapy that we're giving to women all across the globe. However, how do we know that those results are applicable to Black women, to Hispanic women? So that's why we need to look at these populations. There are also new drugs that are coming out in the market. One of them is a PI3 kinase inhibitor, which looks promising, but we have no idea if the mutations that respond to this therapy, how prevalent are they in women of color? So these are the types of things that we really need to uncover so that we can know that the therapeutics that we are delivering are going to truly help these populations.
We have another
That's right.
audience question. Dr. Barmos, can you comment on the stain of eugenics in medicine and why this might contribute to caution and hesitancy to participate in clinical research?
Yes, there's a history that you heard about in the discussion with Dr. Green that extends well beyond the Tuskegee study, and I think these are matters of concern. But I do think that the medical community has responded to these concerns with a much clearer formula for how to make our studies not only more ethical in nature, but clearly consented to by patients who participate. So, we need to build more trust. One way to do that is to have more people of color who are doing medical research. And another is to be sure that we follow the guidelines that have now been put into place that are not necessarily always appreciated by people who are participating in these studies. And I think it's important that we recognize that what we can now do is go well beyond simple racial categories to try to identify the actual genetic factors that contribute to risk, to therapeutic response, and to outcomes in a way that was not possible before. And I think we all agree that it's not sufficient anymore to say someone is Black or Hispanic. What we want to say is that they carry a genetic variant that we can respond to in a much more precise way. You don't really want to treat everybody in the same way when we have the tools that allow us to discriminate among. Don't mean that in a bad way, but we can distinguish between people who have genetic variants that we can understand and as contributors to outcomes.
We have one more audience question here I'd love to get to. How does age impact treatment outcomes in conjunction with race? Dr. Balogun, can you address that one?
So that's in terms of age and race, as it impacts endometrial cancer. I'm not sure, was the question directly about endometrial cancer or in general?
I think the question was in general, but I think if you want to address the specific, that would be fine.
So when it comes to endometrial cancer, unfortunately, what we see is the older you are, the more likely you are to die of your disease. We're not quite sure why, still teasing apart the reasons for that. Endometrial cancer tends to occur in women who are over the age of 60, but alarmingly, what we see is that it's starting to be seen more frequently, especially within women who are 30 to 39 years of age, and their rates of death are also increasing. So when you see these kinds of trends, it's very disturbing. But back to your question about age and race, the interplay, when it comes to cancers in general, I think when you're older and when you're a minority, that can tend to introduce bias into the treatment plan. So unfortunately, elderly women who come with issues or come with medical problems may be more likely to not be taken seriously. When it comes to cervical cancer, Black elderly women are less likely to receive the appropriate therapy, which consists frequently of chemotherapy and radiation, both external and internal. So that interplay of age and race definitely can be a negative in terms of cancer outcomes.
Okay, we're going to have to leave this conversation here. I'm sorry.
because we do now recognize that older patients do get undertreated, and then there's a major movement within oncology to be sure that older patients have the options of getting the most up-to-date and most successful therapies to avoid the prejudice of aging, which is a serious one.
And we'll leave it there. Dr. Harold Varmus, Dr. Onyinye Balogun, thank you so much, both of you, for joining us to talk about genetic research and cancer.
Thank you.
A reminder to our audience that we would love to have your participation. Again, there is a Q&A function at the bottom of your screen. You can use that to submit your questions to us. Sometimes you take us in new and interesting directions that we love. So it's time for our next conversation. We're going to be talking some more about clinical trials. Let me introduce Dr. Karen Winkfield. She is Executive Director at Meharry Vanderbilt Alliance and at Stand Up to Cancer Health Equity Committee member. Dr. Carol Brown is also with us today. She is Chief Health Equity Officer at Memorial Sloan Kettering Cancer Center. And we also have Dr. Lori Pierce, President at the American Society of Clinical Oncology. Thanks to all of you for joining us here today. So we've heard a lot today in the previous sessions about the lack of diversity in clinical trials. And with the three of you, I'd like to delve into this a little bit more. First of all, Dr. Brown, tell me, is the situation improving at all? Is it getting better? We've been talking about this for a very long time.
So I think the situation is absolutely getting better over the time that actually the three of us have been working in this space over the last 15 or 20 years. And I think the main reason for that is the national focus and the focus of the National Cooperative Clinical Trials groups and groups such as the American Society of Clinical Oncology on emphasizing the importance of the participation in cancer clinical trials to all patients, to patients who historically have not been included. And I think we're starting to see these efforts pay off. Some of the data that I'm sure that Dr. Pierce can talk about is that we are seeing an improvement as we educate patients and make them aware about the importance and the availability of participating in clinical trials. They are definitely participating in greater numbers, but we do have a long way to go.
Why so long? Why such a long way to go still? What do you think is the biggest obstacle in your opinion? Dr. Brown, since you were speaking, let's start with you and I'll get the opinion of our other two panelists as well.
Well, I think one of the greatest challenges is the way that our healthcare system is structured. And I think that was alluded to a little earlier by our two previous speakers. The fact of the matter is that 70% of cancer patients in the United States don't receive their care at a comprehensive cancer center or a large health system. They receive it in their community. And I think the biggest challenge is how to effectively bring clinical trials to patients where they are receiving their cancer care in the community. So I think that's one of the biggest challenges that we face.
Dr. Pierce, what would you say is the number one challenge to getting more diversity in trials?
So it's complicated, right? I certainly agree with Dr. Brown that the majority of patients get their care in community settings. And so that everyone wants to come to an academic center, and we shouldn't be the case that they have to come to an academic center. So we have to set up alliances between the academics and the community practice. And actually, to that point, we actually have an initiative at ASCO with ACCC, which is the Association of Community Cancer Centers, to look at clinical trial enrollment with specific issues, and so that we can bring more patients who are in the community onto clinical trials. But I also want to highlight something else. There was a recent paper that was just accepted into the Journal of JNCI, Journal of National Cancer Institute, which looked at patients who go on clinical trials, and it showed that there was an equal representation whether you were Black or white. So once patients were offered trials, there wasn't a difference in minorities agreeing to go on trials as white patients. So it tells us that this kind of data, it helps us to formulate the right questions. And I think once patients are presented with clinical trials, they go on clinical trials without a difference by race. So we have to look at what the infrastructure is in terms of patients going on clinical trials. Are we offering clinical trials to all who we should be offering it to? Are there barriers for physicians for putting patients on clinical trials? And are the eligibility criteria so tight that it makes it difficult for patients in a broad spectrum to go on clinical trials? So I think we need to focus on those things as well.
Dr. Winkfield, your opinion on what the biggest obstacle is? I am not hearing Dr. Winkfield. Okay, we seem to have a little bit of a technical glitch there. Hopefully we'll work that out. I'm going to continue with the conversation here. A couple of you have mentioned sort of the geographical challenges of getting people into clinical trials, that people aren't necessarily going to healthcare facilities that are involved in trials and so forth. And there might be economic challenges in terms of transportation, in terms of childcare, to getting to the centers where research is being done. I'm wondering about technology. There are so many wearable devices that can collect data, and once connected to the internet can feed data. Is that one avenue that might be pursued to broaden participation in trials? Dr. Brown, let me go to you with that.
I'm trying to. Test.
I think we hear Dr. Winkfield now.
Dr. Winkfield, you hear us now?
Okay.
I can hear you guys fine.
Right.
I think you couldn't hear me before, so I apologize.
Great.
If you can hear me now, that's great. Let me just go back to your original question that you had posed around some of the barriers to clinical trial participation. I agree that we need to do a better job getting individuals in clinical trials to where people are. But the social content is vital. And there hasn't been a lot of attention paid to that. And that's why one of the things that I wanted to point out with respect to what Stand Up to Cancer is doing, they have this new breakthrough grant, which is fantastic because it actually is requiring individuals to make sure that the community is at the table, up front and center, early on in the course of the development of a clinical trial. And that's something that's new and unique. We've been talking about the unequal burden of cancer, the inability for communities of color to participate for over 20 years, right? The Institutes of Medicine had their unequal burden of cancer document that came out in 1999. If we keep doing the same things, we're going to get the same results. So it's time to be innovative and creative.
We have an audience question here, which is whether healthcare advocacy organizations are attempting to reach underserved communities using virtual methods. Are there any virtual outreach best practices that you could recommend to reach populations that would normally not be reached through other grassroots efforts? Who wants to handle that one? Raise your hand. Let me know. Virtual efforts. Are any of you using those to try and increase? Yes. Okay. Dr. Winkfield, you're a winner. Go for it.
Taker, sweet. The things, I think there are some very innovative strategies ongoing with several large clinical trials that are happening around the country, mainly around getting biospecimen collection. So you may have heard of the Count Me In study, which is looking at a variety of different cancers. Originally had started out looking at breast cancer. But what they're doing is they're going direct to patient and saying, would you be interested in participating in this clinical trial that may help us identify key drivers of cancers? And in fact, they have a very large focus on the enrollment of traditionally underserved populations, doesn't matter whether it's age or race, ethnicity, or geography. Similarly, the PROMISE study, which is looking at multiple myeloma, which is actually looking at people who may be at high risk of developing multiple myeloma, which absolutely impacts the African-American community. They're at 2.5 times the risk of developing it. And they are actually one of the Stand Up to Cancer awardees. So I think there is an opportunity to use, whether it be websites, social media, other direct-to-patient ways to connect with individuals who may be interested in participating in clinical trials.
And that links up with my question that I asked previously about technology and whether that can help drive minority participation, because it's easier to collect data remotely than it once was.
I think we all will. The only silver lining I'm aware of from the pandemic is telemedicine. And I think a lot of research groups are going to think about how to incorporate telemedicine in how we do research and do it in a smarter way, so that we can increase participation from minorities, rural communities, just people who have generally been underrepresented in clinical trials.
I'd love to get to some of the approaches you all are taking to address this. Dr. Brown, you've mentioned partnerships with community hospitals. Are you confident that this is going to be the approach that's going to drive diversity in trials?
Well, I think there's not one size fits all solutions to this, but I'd love to describe a program that we've developed here at Memorial Sloan Kettering that addresses some of the issues that you just brought up. So understanding that patients get their care in the community, we partner with 3 New York City Health and Hospitals cancer centers to bring clinical trials and to these patients where they are receiving their care in Queens, Brooklyn, and East Harlem at the Kings County Hospital Center, Queens Cancer Center, and Metropolitan Hospital Center. And it's a combination of both the traditional in-person enrolling on trials, and we have a specific program that's used the techniques of tumor genomic profiling and molecular genetics that Dr. Varmus was describing. It's called our Impacted program, where we do tumor genetic profiling to end disparities. And we've actually gotten over 400 underserved patients. Majority of them are of Black race or Hispanic ethnicity. The majority of them are covered by Medicaid or uninsured. And what we've seen is just what Dr. Pierce said. We have not encountered the barriers of mistrust. Patients are very, very eager to get this information. They're very willing to participate. And the way we've incorporated new technology is that when a patient is found to have an inherited genetic defect that might predispose them to getting cancer, they need to have counseling with a certified genetic counselor. And so we developed a telegenetics program for these patients so that they could get their genetic counseling with a genetic counselor at Sloan Kettering while they remained at their home site hospital. And this has actually been very, very effective because we've been able to, out of those over 400 patients, we've been able to identify clinically useful information for their oncologists to use to guide their treatment, either participating in a clinical trial or using some other type of targeted therapy or immunotherapy, as was mentioned by one of the last speakers. So I am confident that this is an approach that can work. But as I said, there's not one approach that works for every situation.
Dr. Winkfield, Stand Up to Cancer announced in January that all future grant proposals for funds will require the recruitment and retention of patients from diverse ethnic groups. Is that a unique approach in the funding space, or are you seeing that widely adopted?
Well, as you know, the NIH has had requirements for the inclusion of women and minorities for years, but many of these large institutions that are writing these grants know how to write grants and write them well. And sometimes they also know how to write reports and write them so that they address some of those concerns. Stand Up to Cancer is unique in that because they're a private foundation, they have the capacity to actually act on and to really put people's feet to the fire. And it's already working. Frankly, I know in Boston, one of the things when I was there, I had recommended one of the large institutions to partner with the city hospital to do clinical trials there, because in my work, in going out to the community and asking what some of the barriers were, they didn't want to go to a big cancer center where they didn't know any of the providers and it felt cold and unwelcoming. They wanted to be treated where their primary care doctor was, for instance. And that was the suggestion I made. And the answer was, we're not going to do that until Stand Up to Cancer made this announcement. And now, actually 2 weeks ago, it was announced that that collaborative with that city hospital is now happening. So I think that they have a very unique way that they can actually hold people's feet to the fire and say, you've got to do this or else.
Dr. Pierce, as leader of the American Society of Clinical Oncology, you set health equity as one of your priorities. How does diversity in trials fit into that larger picture?
Oh, it's a huge piece. And so as a part of what we're doing, as I mentioned earlier, we have a collaboration with ACCC, which are community practices, that we are looking at the enrollment of minorities onto clinical trials, and we're looking at potential pathways to improve that enrollment. And so what we're doing is we have a committee of experts who have worked on accrual of minorities in clinical trials for their careers. And we're putting together a pilot of some of the key things that we're finding in our research and feedback from our group that we are going to try. Because if we find that we are able to improve enrollment in that pilot, we then want to disseminate that methodology to our cooperative groups. So diversity and presentation of minority patients in clinical trials is very important so that they get the best possible care, as we know is offered in clinical trials. And we know that our therapies are work in these populations and they're safe in these populations. So it's a win-win to increase diversity in clinical trials.
Dr. Pierce, are you seeing more coordination across the healthcare system, that more and more people are working together to create the needed diversity in trials?
Oh, very much so. At my institution in ASCO, everything ASCO does is to improve quality of care. And there are so many parts of ASCO that are working, and now we're all working together. So all the pieces are being connected. And so we know that advocacy, we know the social determinants of health, all the pieces are coming together, and it's a wonderful thing to see. And I think our patients will clearly benefit from that.
We have an audience question. Alexandrina asks, how do low healthcare literacy and or language barriers impact minority participation in clinical trials? Dr. Brown, do you want to try that one?
Certainly. I think it's very important to look at the issues of primary language spoken, as well as a person's culture on how they can affect their their participation in clinical trials. And I think it really all boils down to something we brought up before, which is communication. As Dr. Pierce mentioned, there's been study after study that shows that if you explain to patients with cancer about what clinical trials are and how they can benefit them, there really is no difference in people participating based on many of the demographic lenses we've discussed. And that's also true for language spoken, as long as you develop the tools and technologies to communicate effectively. So with regards to the tumor genomic profiling study that I mentioned, we have a video that we show patients that has cartoon characters to explain about profiling your DNA versus your tumor's DNA. So we really had a very hard time, understandably, enrolling patients whose primary language wasn't English until we got that video translated and dubbed into different languages. And then we were able to we really saw an uptick in terms of patients' participation. So, and I think that video is also a great example of how you deal with low literacy, which many people have with regards to healthcare, and certainly with cancer. It doesn't correlate really at all to their level of education. And the use of things like cartoons and videos is really very effective. So I think that these are really critically important things to take into account as we're trying to expand the access for patients of a lot of different demographic diversities into clinical trials.
We have been talking largely about ethnic and racial diversity. I'm wondering about gender diversity, which historically was a big obstacle. I don't know if that's been adequately addressed yet or not. And we also had an audience question earlier about disability and whether people with disabilities are represented in the clinical trials. Dr. Pierce, do you want to take a stab at that?
It is important for diversity, no matter how you define diversity, for patients to be represented in trials. So with regard to disability, with regard to rural, with regard to age, race, ethnicity, all of those factors are so very important so that, again, we know our therapies work equally in all populations and are safe in all populations.
We have another audience question. Are there some types of clinical trials that are more likely to include racial and ethnic minorities than others? What differentiates those trials? Well, I would guess outreach and education are some of the factors. What else would be a factor? Would it be the type of cancer being studied and whether there's a higher incidence of that in certain minority populations? Dr. Winkfield?
Yeah, it's a great question. I think certainly the type of cancer that's being looked at, if you're looking at prostate cancer, we know that Black men have twice as high an incidence of prostate cancer than white men. And so certainly if you have a prostate cancer clinical trial, one would anticipate that you might want to have higher participation of Black men. So it is really related to the type of cancer, but it also really depends on where the studies are being done and what their approaches are. Dr. Pierce mentioned one of the challenges in terms of how clinical trials have been designed traditionally have these inclusion and exclusion criteria. And oftentimes, things like diabetes may exclude people from a clinical trial. Things like obesity. I remember there was a clinical trial that I was asked to be the PI of, where they were excluding people with BMIs or basal metabolic index more than 25. That's more than 70% of the population. So I do think it's really important to look at how the clinical trials are structured. That's really important. What types of clinical trials and what the questions being asked are. But if a study is designed with the intent to look at of the disparities, it's automatically going to make sure that the inclusion criteria are just that, inclusive.
And we're going to have to wrap up the conversation there. I'm sorry, but time has run out on us. Dr. Winkfield, Dr. Brown, and Dr. Pierce, thank you all for joining us and sharing your wisdom here today. And that concludes today's program. Thanks for watching and participating with your questions. Thank you also to Bristol Myers Squibb for supporting the Atlantic's journalism today on this important topic. Please join us next week. We are going to have a second episode in our series of cancer in the, we're going to be looking specifically at cancer in the age of COVID. Please visit theatlantic.com/live for more information on that event and other virtual events that are coming up. And also, let me highlight the final event in our People v. Cancer series, which is going to be held on November 18th. We will see you all soon. Thanks so much for joining us here today. I'm Jeanne Meserve. Be well.